Bartholomew Town is brought to you in part by the University of Rhode Island Online, Navigant Credit Union, the Audubon Society of Rhode Island, Newport Film, and Half Street Group.
Bartholomew Town.
All right, folks. Well, I mean, it's a conversation that is, it's just something that is embedded in our general discussions right now. And broadly speaking, mental health, and specifically speaking, behavioral health and the resources therein. Look, right now, the country is clearly in a mental health crisis, and Rhode Island not immune from that in any way, shape, or form. This can be tied to a lot of things. The digital era, it can be tied to the post-COVID era that we're in right now, and just, I think, human nature in general, and also a recognition that this is real. It is health in the same way that your blood pressure is health. And I think that we're finding more of a holistic approach to dealing with this type of crisis than we ever have, perhaps in human history. I mean, maybe going back to indigenous times is the last time you can find it. So really broadening it out on the mental health side is something we've done a lot of. We're going to narrow it in right now on behavioral health. And we've got Tom Rodrigues, a mobile crisis clinician who joins us on the podcast today. Tom, thanks so much for the time.
I appreciate you having me on, Bill.
Let's get right into it. Your assessment of behavioral health in the state of Rhode Island right now is?
Well, I think you put it very well. This is not something that started at COVID. Pre-COVID, we were still having a lot of mental health issues, of course. But as we're seeing is after 2020, these things only became much worse. And now in the current times that we're in and the climate that we're in, it only seems to be worsening. So it's overall unstable for a lot of families right now. We're seeing in families and schools. So it's like the rest of the country, as you said. It is not where we want to be.
What would you say to somebody right now who's dismissive of this? And I know we're getting right into sort of some negative energy, but I don't know. We hear too often in the context of mental health in general, even specifically with behavioral health, that it's environmental, that we've just kind of lost some sense of standards in this country. I mean, you hear this kind of nonsense all the time. What's your reaction to people who are dismissive of this crisis?
Well, I would just say, look at the outcomes. Look at what we're seeing. We're seeing that the numbers of folks who are using, and total folks too, especially with MRSS. So MRSS is the Mobile Response and Stabilization Service program, which is now embedded in every city in Rhode Island. Every town and city in Rhode Island has this service. We're talking about really children and families in a big way. And we're seeing children at very high numbers using substances, children reporting depression, children on medication for depression and anxiety, children expressing suicidality, children who are attempting suicidality. So, I mean, we can talk, theoretical and that's a whole other conversation, but the outcomes are what they are, and kids and families need help right now.
Yeah, clearly that is exactly what it is. There's a need, and let's address that need. So give us the rundown in your work on from a mobile response standpoint. What are some examples of effective strategies that you've been able to deploy in terms of combating this crisis?
So what we're doing with MRSS, the mobile crisis team, is we're a diversionary program, which means diversionary from the emergency room. So if we did not exist, MRSS, there would be a lot more. These calls would be going typically to, Hasbro Hospital. You'd be calling 911. You would have to have, emergency services arrive when children are even feeling suicidal or homicidal or having big behaviors. They would be going to get an evaluation to see if what they need is possible a higher level of care. What we do at MRSS is we try to meet people where they're at, wherever you're at when you're in this crisis, and we try to meet you there immediately. So whether you're at the school, whether you're at home, if you are experiencing a mental health crisis, we want to meet you where you are as soon as possible. And what we do is we are evaluating to see if you need to, if you're okay to be, if you're safe to be home, if you're safe to stay in school, or do you maybe need to go to Hasbro for a more enhanced evaluation and possibly more enhanced services? But we have found that 97% of the time is these kids are able to be safe at home with a safety plan and with some different techniques that we try to work with those kids in the moment.
Mm-hmm.
We also connect in the services as well. But in those moments, what we're trying to do is help teach them coping skills, like distress tolerance. But also, to be honest, the biggest piece to this is just giving them an outlet to talk about a really tough conversation, which is, I'm feeling like I want to end my life. That's one of the most common calls that we have. And especially for a child to be able to have these big feelings in a little body can be so overwhelming. And you know how it can be when you're that age. You kind of feel like no one understands you. So when you just have that opportunity to talk to someone in a way that's very destigmatizing, non-judgment. We always tell kids when they first come in, like, listen, this is not anything new to us. There's no judgment here. You're in no trouble at all. Because, of course, it can be, as much as immediate assistance to your home can be very helpful, it can also be a little bit intimidating to have a couple of strangers coming into your home or your school and they will ask you some tough questions. But we really try to be very non-judgmental with them, let them know that, we understand that they're children, and whether the behaviors, they're behaviors that are maybe more aggressive to others, or whether it's feelings about hurting themselves, completely normal for what's happening for them. And we find that many children actually say just after that first interaction with us, they're already starting to feel a bit less either suicidal or distressed. And then we get reports from those in their space, whether it's their parent or their teacher, saying that we're noticing already that they seem to have a little bit of improvements already, just from that opportunity to talk about something that feels like taboo you can't talk about.
Yeah, well, that's it. And look, we're in an era right now where therapy is accessible from a telehealth standpoint. It's accessible in schools. There's a lot there, but sometimes, it's really a situational thing, and that's where you come in. That's sort of the response that you're talking about. Give us paint a picture of, it's difficult to rank Rhode Island as compared with other states, and I know that you're working here. So, but in terms of the field itself, I mean, where does Rhode Island rank in an anecdotal sense in terms of managing the behavioral health crisis that's impacting really the whole world, but specifically the United States? Are we doing a good job? Do we have enough resources from state and municipal leadership?
We could always have more resources, of course, when it comes to this, because there is a concerning amount of children and families who are in crisis. However, I will say, especially as of October 1st, there was an initiative, the CCBHC initiative, and that is something which ensures that every town and city in Rhode Island has limited to no barriers to getting access to mental health. And EOHHS has been vital in this, ensuring that we get the CCBHC program going on. And MRSS, so mobile response, is embedded in every one of these CCBHCs. So in terms of that, Rhode Island is really doing a great job in ensuring that there's no barriers, right? If you give us a call, whether you have insurance, no insurance, what insurance you have, and what's happening for you, and any other kind of variable there. If you live in Rhode Island and you're a child or a family with a child in crisis, just give us a call. And if we're going to do everything we can to help you out regardless of the barriers. And I would say I've only worked in Rhode Island, so I can't speak to how it works in other states, but I would say especially as of October 1st, we really we had to admit that people were facing barriers. People were suffering on these long wait lists for outpatient. We have parents who are calling all the different programs, and one program tells you to call the other program. And we were working a bit siloed. So now we realize we need to work together. We need to not put the stress on the parent who's trying to get their child services. Like, hey, you got to figure out how to, listen, just give us a call. And if, let's say you called, the FSRI mobile crisis team, but you live in a state, or rather a city or town that is served by, say, Tides. We're not going to say, hey, wrong number. We're going to connect you to Tides with a warm handoff. We're going to make sure that since you made this call, we're going to make it as easy as possible for you to get connected to services as soon as possible. Yeah. And the CCBHC model has helped us do that as well. And So I will say overall, Rhode Island is putting that in place. I would just definitely want to encourage that we continue to do that. And again, we can't have too much funding in this way, especially when it comes to this being a very proactive and preventative type of intervention. And you think about resources saved by doing it this way. If you kind of picture, like, a lot of times we report to schools. So a child in a school reports to their school social worker and they say, I'm having thoughts about ending my life. And okay, school social worker says we need to get this evaluated. Had we not existed, now we're talking about the amount of resources that has to go into that. Now that's a call 911, that's fire department, that's police, that's ambulance, that's bringing them to Hasbro now for hours. And instead, now it's just, a couple cars, me and a case manager, or, the clinician and the case manager going out there and just going right to the school, talking to that child. And that's the amount of resources we can save in terms of, call it dollars, you want to call it time, or call it intention, it's resources in the beginning of that crisis versus dollars you have to spend if A, that child has to go to Hasbro, or you call 911, or B, if they never get services. And obviously we can figure out what that could happen to those who their needs are unmet. So it's with money well spent, and it's in terms of the resources.
What can people in the community that are, just trying to be better connectors themselves do to recognize when it's time to make a call to you?
I would say really there's no wrong, never too early. You can be too late, but you can't be too early. So if you have any type of suspicions about someone in your life, now granted, if you're going to be making a referral to us, we do want you to have that be a conversation with that person first. Because, I'll say that again. You can call us and you can talk about what's happening for that person, but this is a voluntary program. It's not that you can call Mobile Crisis and say, I think this person is in need of a crisis, and we'll just go to their home without them knowing about it. It needs to be voluntary. So if in doubt, call. But in terms of some of the signs, the things to look for, think about the baseline. If somebody's baseline is that they're typically very invested in certain activities and that's starting to wane, if they're making any type of comments about feeling hopeless, about feeling worthless, those type of things, if there's any concern at all, if you call us too early and, we end up saying, we screen it out, we talk about it, and you talk to them and it's okay, then that's fine. Versus if they make an attempt or something like that. So never too early. You can only be too late.
That's a huge statement. It's a huge and important piece of advice, and it's something that we really need to keep in mind. No question about it. I guess lastly here, just sort of, are we trending in the right direction right now in terms of assessing behavioral health? It seems like the crisis has gotten much worse. Again, data can support that. It's difficult to break that data down because we don't know how much underreporting has taken place in years past. But the factors in the world right now that are certainly very real and difficult to navigate are seemingly more aggressive than ever. But are we, with the responses, things like what the work that you do, for example, are we trending in the right direction? Do you have an optimistic view of where we're heading at this point in time, given the resources that are being deployed?
I do, only because I feel like this is a time that we're really putting intention towards this. I think that we have in the past, but when you're putting forth intention and resources in ways that was, again, siloed, everybody kind of doing their own thing and not knowing what's happening with the other, then it wasn't nearly as effective as it is now. So I've been in the field now for about 15 years, and seeing it seems like small differences in terms of ensuring that people can get that warm handoff to the other agency instead of having to let them know, hey, you called the wrong number and call this number. Well, oftentimes, and self-disclosure, I'm a parent too, so I understand this, right? You tell a parent, hey, call this number, it's really important. Well, so is everything else that they have to do. And also that number doesn't get called. And that little change of being able to say, you called, this is not, we don't serve you because you're not in our city for mobile crisis, but we're going to now hand you off to this person. I think that seems like a small difference, but it's a big one. So I'm optimistic in a sense of, for the first time, we're actually now working together as a state. We're talking to each other. If that's because we have different catchment areas or whatever, that's all that other back end stuff, we're not letting that get in the way. We're removing the barriers. That makes me optimistic. Now, obviously, as you stated, there's a lot of things happening now in our country. There's a lot of things happening for us in our state, and there's a lot of things happening just in our world. You know, where, like you mentioned in the beginning, the digital crisis, right? These are things that as a species, we're trying to adjust and adapt to so many new variables now. And that, of course, is causing some issues. So I'm really glad to see that we're actually starting to say, well, we can't just assume that people are going to be okay. We have to actually make this part of the conversation. We also need to get away from old habits of not talking about mental health. You know, that's something that we're working a lot too with families, that type of cultural piece where it's like, you know, you're fine. You know, a lot of what we do sometimes is helping parents. Excuse me.
Getting calls right now, big time.
Look at that.
It's nonstop here.
Yes. So for example, this will give you a kind of day-to-day look at it. We get a call and we will talk to that person. We'll get out there, and depending on what's happening in that situation, we will be able to, we're not tied to one like clinical structure. We can kind of bring whatever the family needs. And one of the things that sometimes often is helpful is to talk with parents and speak with parents and help them understand too that this is not a failing on their part, right? So they oftentimes they wonder, why can't they just tell me what's happening for them, and try to help them understand that that's a very normal thing. A lot of the kids we see are very empathetic, they care, and they don't want to make you feel worried about them. So there's a family education piece to this as well. And also with MRSS, we have we don't just respond in the moment. We have a 30-day follow-up window as well that families can voluntarily engage in. And during that time, we can come and do more follow-up visits, weekly home visits, once or twice, whatever is needed during that 30 days. And also connect you to any other kind of services as well for the whole family, no matter what it is. Because when you help, and as you said in the beginning, a holistic view of this, when you are looking at a child in crisis, they're only having their own little crisis. Oftentimes, kids, we don't realize how smart they are, perceptive they are. They know if the family's having financial issues, right? They know if mom's having something going on with her, and that's causing them some anxiety or animosity, some big, overwhelming feelings. And so when we help anybody in the family with connecting them to different services, we also help that child as well. So we're there to do whatever we can for families. And we're a screen in, screen out program. Rather, we're a screen in, not a screen out program, meaning that if you give us a call, we're going to find a reason to go out there. Instead of saying like, you don't really meet our criteria. Our criteria is very relaxed. It's very open. Just you can give 988 a call in Rhode Island, 988, and they will connect you with the correct agency, whether it's us, whether it's Tide, whether it's Gateway or East Bay or Thrive, all the different agencies involved in a CCBHC. You can give us a call directly at 401-854-6678, and we're gonna screen you in. We're gonna find a way to help you, no matter what that is.
Tom Rodrigues, thanks so much for your time. Massive conversation, massive importance, and to be honest with you, you're doing some amazing work out there, man. So thanks again.
I appreciate the time, Bill. Thank you.
Hey, thanks for stopping by Bartholomew Town. For more content, follow me on Instagram at Bill Bartholomew.